Good morning, good evening, and good afternoon. This is Nitish Devnath, One Health Coordinator from Bangladesh. Welcome you to our second webinar on COVID-19, and this is organized by One Health Bangladesh in collaboration with Global Health Development and FINA. I wish you all are well and safe in this difficult moment, and I'm very grateful that even in the weekend in Bangladesh, you are attending this webinar. And I know it is also a Ramadan, not very easy to wake up. As you all are aware, we have today two very important speakers to enlighten us on the topic, what we know and what we don't know about SARS coronavirus type 2 and the COVID-19. And I would like to take the privilege to introduce you first, these two speakers. First of all, I would like to introduce you Professor Steve Luby. All my colleagues in Bangladesh is aware of him, and he is a very, what we call one of the most known person in Bangladesh scientific community, particularly One Health community. He is a professor of medicine in Stanford University. He has another strong identity, in Bangladesh. He is the pioneer in establishing the association of palm safe drinking and Nipa infection in human beings, which is another potential pandemic pathogen. Above all, he is one of our strongest mentors for One Health movement in Bangladesh. There's a lot of things to talk. I will not go further on that. And we have the second speaker, Dr. Jonathan Evstein, who is also very popular to Bangladeshi One Health colleagues. He is a veterinarian, a One Life health expert, working as a vice president of EcoHealth Alliance. There is a similarities between these two speakers. One was involved in establishing the Nipa transmission from palms in Bangladesh and John was involved in 2002-3 with SARS coronavirus that was first identified in China and then spread to Southeast Asia. And he was one of the key persons who investigated the global spillover from Kobit to human being and as a virus from bear. And he is still very active in investigating and hunting for virus all over the world. You all know about the PREDICT project, as he is one of the most important key players in this thing. So this is all about our two speakers. There is few housekeeping announcement before we go to the presentation. All participants will be able to ask questions by writing in the chat box, and this deliberation will be recorded and then finally will be uploaded in One Health website. The first speaker will be Professor Steve Luby. He will come up with a big presentation followed by some comment from Jonathan Evstein, and then we'll go for question and answer. It will be a 1 hour session, and with these few words, I will request Steve, you please go ahead with your presentation. Thank you very much for coming to our webinar. Go ahead.
Thank you very much for the invitation, Nitish. It's always a pleasure to be a part of the One Health community in Bangladesh, and I think the leadership of this community is really well recognized globally. So I'm going to talk just for a little bit, 10 or 12 minutes really, to just give a little bit of background on what we know and what we don't know about SARS-CoV-2 or COVID-19. So it turns out that we know a remarkable amount. Just since January 1st, 2020, there have been 6,000 peer-reviewed articles on coronavirus that have been published. So that's not even counting all the news reports, all the commentary, everything else. There have been 6,000 coronavirus articles published. I've read, I don't know, somewhere between 1 and 200. So I'm going to count on John having read the other 5,800 so he can round out what it is that we know. So given all of this, and given even the larger amount that we don't know, what am I going to talk about in 12 minutes? Just 3 issues. First, a question that many of my Bangladeshi colleagues are asking me is, are Bangladeshis more resistant to COVID-19? Maybe because they received BCG vaccine, maybe because of sometimes taking chloroquine. Why is it that they're not seeing the same number of deaths in Bangladesh, and does this indicate resistance? Second area I want to talk a little bit about is prospects for vaccines, and then offer an idea to protect health workers. So looking at the Chinese data, it suggests that most SARS-CoV-2 infections are mild. So look here in the less than 20-year-olds. It's 0.00, either 2 or 7%. So very low rates of fatality among young people, children who are infected. Even when we get to young adults, the rates still are really low. Even up to the age of 39, people in their 30s still don't have 0.1% of an infection fatality ratio based on the data in China. And I'm using the data in China because it's some of the most complete data that we have. If we go up a couple more decades into the 40s and through the 50s, we're still not even at 1%, 0.6% among people between the age of 50 and 59. Estimates from China go on to die. And it's really not until the 7th decade, until the 60s, 70s, and 80s, that the infection fatality rate rises. And it rises considerably. Now, some people have looked at these data and said, yeah, but do you really trust the Chinese data? They were late to say it was coming out. They've got all this control on the internet. Do we really believe these data coming out of China? So let's look at some other data. The Diamond Princess, there were 3,711 crew and passengers, a mean age of 58 years. They did over 3,000 PCR tests, and they identified just short of 700 cases. So an older population here, their overall infection fatality ratio was about 1.3%. Now this is an older group. Over the age of 70, 6.4%. So you look at those numbers from the Diamond Princess, and they look pretty similar to the numbers from China, suggesting, and I'll argue that as we look at other data, we see this same pattern. So, so here are the data again from China. One of the things that, knowing that fatality depends so much on age, it's worthwhile to understand the age structure of our populations. So Bangladesh is known to have a young population. Most of the people in Bangladesh are below the age of 50. So if we look at this part of the population pyramid, so that's the males on the blue, the females on the pink, you can still see over the age of 60 is a pretty small bit of the overall population. So we would predict, even if we get the same age-specific infection fatality rates that we're seeing in China, and they happen in Bangladesh, we're actually going to see fewer deaths. And let's contrast this with Italy. Look at the age pyramid in Italy, what you see is there are many fewer young people in Italy, many more middle-aged, and many more elderly people. So now look at that over the age of 60, when we're over 1%, again, we see many more older people in Italy. So we would predict, using the same infection fatality ratio data coming out of China, there's going to be a lot more deaths in Italy on a population basis than there would be in Bangladesh. And indeed, the mean age of a COVID-19 death in Italy was 81 years old. So my argument is that we would predict that most people in Bangladesh who get infected with this virus will have mild illness, and that there will be fewer fatalities because of the younger population. So this is just very clear. Here's some more data on case fatality ratio. Case fatality ratio is a little different from infection fatality. That is when you actually recognize you have an illness. So here's the case fatality ratio, but showing that same increase by age. And I want to compare this to another population. This is a population in my home state in California, and up north of us in Washington state. There are 10 million people in these two areas that are part of this same health maintenance organization. So they always get the care by going to their same facility. And because of that, we're able to calculate a population denominator. And what this shows is the same thing I've shown previously, that as age goes up, then this is the proportion of people who die among those who are hospitalized. So first we started with only infection, then with cases. This is among hospitalization. But we're seeing the same thing. If you're young and hospitalized, you do pretty well. The older you get, the higher the probability of death. But I also want to make another point here. And that is, if you look at like the eldest males, they're almost twice as likely to die as the females. And that's true even as we march down the age set, the age groups. So this is another characteristic of COVID-19. We see it in California. They saw it in China. We see it in Iran. We see it in Italy. Male sex is an increased risk of death. So I would predict that in Bangladesh, the deaths are going to be concentrated among older men. So let's turn to how we might get out of this. I would argue that vaccine development is promising. One of the reasons I say that is because some diseases, some infections we know are just very hard to develop vaccines against, like HIV or hepatitis C. And they've been trying for decades to develop vaccines, and we don't have them. But for coronavirus, we already have effective veterinary vaccines that are available against porcine coronaviruses. So that suggests that as a group, these are diseases, these are infections that vaccines will work against. There are over 80 SARS-CoV-2 vaccines that are currently under development. However, if you talk to industry experts, they say that the typical pathway from the research beginning to look into a vaccine until you have a vaccine in the market, the average is about 15 years. And the reason is, first, that there's a lot of initial work to figure out what might work. There's a lot of preclinical development. Preclinical development means before you ever put it into a person. That even once you say, well, look, this is pretty promising in an animal model, now let's work for clinical development. There's a lot of vaccine purity work that needs to go on. Unless you've done some initial safety studies and then more advanced studies, it takes a serial process to work through, not only to test safety of vaccines, but then also to test their efficacy and to get approval. Now, we are in unprecedented times, so this may be able to move somewhat faster, but you still have to go through those hoops. And even once we get a vaccine, one of these 80+ vaccines that are in development that will that does turn out to be protective, and we've got every reason to believe that several of these candidates could get there, then we actually have to make the vaccine. So we have experience with something like influenza trying to make vaccine, and we know that when H1N1 came in, vaccine could not be made fast enough for all of the demand in the world. So looking at vaccine production capacity in 2015 and estimates of the potential supply from the time you have the vaccine, so you can't start ramping up until we even have it, and that's going to be some ways away. Looking at reasonable projections, it would take, by 6 months going at full speed, you'd have enough vaccine to cover 12.6% of the world's population. You would need 12 months to get to 36%. So even once we have vaccine, it's going to take a long time. So I would argue that it is unprecedented. It's not really unprecedented. There's been one example when a vaccine has been developed during a pandemic soon enough to stop the pandemic. And that was an outbreak that occurred in Hollywood during the movie Contagion. Other than Contagion, other than the movie, we've never been able to do this. So I'm not saying it's completely impossible. I'm saying it's really hard, and we're not going to see it in 2020. In Bangladesh, Dhaka Tribune notes that we've had over 500 healthcare workers diagnosed with COVID-19. I've seen different numbers talked about, over 500 healthcare workers, maybe even over 500 doctors. So we know that a lot of healthcare workers in Bangladesh have become infected with SARS-CoV-2. This contrasts to Singapore, which has identified 66 healthcare workers that were diagnosed with COVID-19, but on investigation, none of these were thought to be infected through work. And I can tell you my home hospital, Stanford, has just finished testing 11,000 healthcare workers in the last 2 weeks, and none of them, 0.03% were shedding the virus. And again, they didn't find any transmission from patient to healthcare worker. And why is that? Because there's been really intense investment on procedures and use of PPE and focusing, closing down much of the hospital activities just to focus on COVID-19. But that's not what we're finding in Bangladesh. We're finding lots of healthcare workers are infected. So I want to suggest that there might be another tool that we could use. Face shields. Face shields work has shown that they reduce aerosol exposure between 68 and 96%, even from aerosols that were expelled up to 30 minutes earlier. They're able to reduce surface contamination of masks, and so that it gives another level of protection to healthcare workers. And it also, if their masks do not become contaminated, then they are less likely to get contaminated, taking their masks off and on. And they are compatible with beards in a way that masks are not. They're easy to manufacture. They are easy to fit. I think these could be made in Bangladesh. And I think that this would be another level of protection in a system that is showing us that it needs protection. So I'd be interested in One Health Bangladesh thoughts on whether this is something that we might advocate for. It looks to me pretty simple to get some of our colleagues in manufacturing to be making such devices. So I just want to close, remind you all to keep washing your hands.
Thank you very much, Steve. As usual, you always come up with something that we didn't expect. This is so interesting and maybe so very directly relevant to our Bangladesh situation. we have been struggling to get some question and answer, and I think it has given some light to have some answer with our present situation. Steve, thank you very much for your wonderful presentation. It's really, really insightful. Now I will ask John, you are an expert in hunting viruses. Now the question is, in the Bangladesh context, and with the presentation that Steve has already made, very different way or different pathway. Can you make a brief comment on this first? And then, of course, you'll have a lot of other questions to come. John, can you please go ahead with your brief first comment?
Well, first of all, thank you very much, Nitish, and to the One Health Secretariat for inviting me. I'll echo Steve's comments by saying that it's always a treat and a privilege to participate in activities with you here in Bangladesh, and so I'm grateful to be part of this discussion tonight. From the virus hunting perspective, SARS-CoV-2 has proven very easy to find, particularly in New York City, where I live. And, I literally live in one of the epicenters of transmission in New York City, Queens specifically. And so we're seeing similar trends, just to follow on the data that Steve was presenting in terms of the relative effect in terms of the death rate in older males versus females. Fortunately, our transmission rate is starting to taper off a little bit, but it is still quite high on a day-to-day basis. So we're still searching a lot of the same answers that bangladeshis, no doubt, and the keys really lie in some of the tried and true processes of social distancing, protecting frontline workers and protecting each other by really limiting our exposure. And I think the idea of face masks and doing what we can to prevent exposure to aerosols is particularly a poignant point, particularly as data is starting to emerge about the potential for this to spread via aerosols and not just droplet spread, which was, dogma for the first 3,000 or 4,000 of the papers Steve mentioned, and maybe by about the 5,000, we started to learn more about the transmissibility or the viability of this virus in aerosols. So there's a lot to pay attention to, but of course, from my perspective, the inevitable challenge of manufacturing vaccines and drugs can all be obviated if we just prevent these epidemics from happening in the first place. And so this is a particularly interesting moment, I think, for me and for colleagues who have been studying coronavirus diversity in wildlife, because we've known that viruses like SARS-CoV-2 have been circulating in bats, certainly in southern China and Yunnan, but in types of bats that are found broadly. Horseshoe bats in particular are insectivorous bats that carry SARS-related coronaviruses and can be found across Asia, in fact, all the way into Eastern Europe. And so the question for me now is, in addition to the obvious need to control this pandemic and get the case numbers down to zero, and that should be everyone's goal, we also need to look forward. And thinking about a One Health perspective, we need to reflect on how we got here again, whether these epidemics truly are preventable, and I would argue they are, and how we can do better globally to focus our resources and our energies to trying to prevent these epidemics from happening. So my perspective on this is that this is a tragic occurrence because we knew better, because we knew that these viruses were actively circulating in the wild. We knew the processes that help them get from bats into people. And in this case, the wildlife trade, bringing animals out from the wilds and into urbanized markets, certainly was what responsible for the original SARS coronavirus emerging back in 2002. And because tonight we're talking about what we don't know about this virus, I would say that we still have an enormous lack of understanding of exactly how this virus emerged. We have a lot of confidence based on data that it originated in the same type of bats that carry SARS coronavirus and related coronaviruses, but there's still a big question as to exactly how it made its way into human populations. And originally there was a lot made of the live animal market that was in Wuhan, but looking at epidemiologic data that shows the earliest known cases of pneumonia, of 41 a cluster of 41 cases, we know that about half of those cases had no association with the live animal market that's thought to be the epicenter for this emergence event, and or ground zero, I should say. And in fact, the earliest 5 cases, and this was a study published in New England Journal of Medicine and discussed further in The Lancet, some of the very earliest cases had no contact or association whatsoever with that market. And it raises the question, which to me is a big unknown, is exactly where were those earliest cases exposed? Now, one hypothesis might be that they were exposed to other people that were infected in the community, so that there was community circulation going on, in November, in early December when those first cases were recognized. Or those people perhaps were exposed to animals in a different market or at a different part of the chain. So one of the big unknowns for this epidemic is really exactly how the first case was exposed and how it began. Also, we know from research that we've done with our partners in China at the Wuhan Institute of Virology that there are communities in Yunnan province, which is some distance from Hubei, communities that live around and interact with populations of horseshoe bats. There are caves of horseshoe bats known to have SARS-related coronaviruses circulating. And we found that when we looked at communities that hunted and ate these bats or entered into the cave and had potential exposure, about 3% of that population were found to have antibodies against bat coronaviruses. And it suggests that even within a community, spillover is not only possible, but has happened. Now, we don't know specifically whether that exposure led to disease, whether there was a severe respiratory outbreak associated with these exposures, but we do know that there's evidence for at least exposure to, if not infection with these viruses. And so it says that not only do we have to pay attention to high-risk activities like urban wild animal markets or live animal markets, but also even at the community level, any activities that create higher levels of exposure to bat populations have the potential to facilitate spillover and in theory could spark an outbreak too. So knowing that there are certain high-risk activities, understanding that there are specific species that carry viruses that many of which have the potential to jump into people, I think we need to also think about and have a plan for trying to address some of those activities and limit behaviors that would put us at higher risk for emergence events, because clearly that has the potential to impact the entire world. So I'll pause there, but that's how I wanted to open up this discussion and thinking about how these epidemics and pandemics originate. Thanks.
Thank you, John. This is wonderful that you have highlighted the issue of origin and as well as your experience in the past. I think we'll come up with some questions now. Steve, you have so many questions, I don't know where to start. But one most example, important thing that you have talked about the vaccine, but you have not really pointed out about any drug. And also nowadays people are talking about the use of chloroquine. I mean, can you really put some light on the drug, a new drug invention or discovery on this thing? There are a lot of questions on this thing. I'm coming up with more, but let's start with that one.
Okay, so I'm more optimistic on timeline in terms of drugs than I am on vaccines. Now, drugs could reduce case fatality rate, but they're not going to reduce transmission. And they're not going to reduce transmission because most of the transmission occurs before people get really sick. They're shedding before they get symptoms and early on. So, but still, if drugs could reduce case fatality, that would be great because it would reduce the total burden of the epidemic. So we now have data from two randomized control trials that remdesivir does shorten the amount of time in hospital. So we now have a drug that's been tested in a good randomized control trial that's going to become standard of care in the US for everyone who is hospitalized. Now, it's a new drug. It had been tested a lot in Ebola. It wasn't particularly effective in Ebola, but because it hasn't had a lot of human testing, we have more confidence of its safety. It's got an emergency FDA approval, and as I say, in the US will be standard of care. One problem with it is it's an intravenous drug. So you can't just give it to anybody. It's going to be limited to those people who are in the hospital. And I don't know, I know that the company said, oh yeah, we have lots of doses. I don't think they have any idea how big the world demand is. And I think that they're going to face a production problem similar to the production problem I talked about with vaccines. Hopefully they'll get out of it sooner rather than later. The other great step forward in terms of having a drug is now nobody who comes in for a trial, and in most centers in the US, people are being offered, academic centers anyway, people are being offered to be entered into trials. So now it's, nobody's going to get any more placebo trials. They're at least going to get remdesivir. And then the question is, do we have something that would be better? So there are some other drugs that are being tested. In terms of chloroquine, well, although my president thinks it's pretty good, I would say that the medical consensus has not been so strong. That the studies that show it looking the best are the ones that are the most deeply flawed. The most recent trial that was a careful randomized control trial was stopped because of increased mortality in the chloroquine group. And this is something we know about chloroquine. It changes the cardiac conductivity in the heart. So I'm not optimistic about chloroquine, despite my current president. But I am optimistic about the prospect that we will have more drugs in the intermediate term that can help to lower this.
Thank you, Steve. I think that's clarified the position. John, you have one other question. What do you think about the second wave? You know, people are talking about second wave, and sometimes it is coming in a different voice, that it could be even stronger than one we are having at the moment. What is your comment? Second wave.
I think the idea of subsequent waves of infection are entirely dependent on context and geography, because the infection is making its way through naive populations all over the world. And at this point now, every country and region has its own activities and systems in place to try to limit opportunity for spread. But for example, in the United States, we still have a small fraction, and Steve, correct me if I'm wrong on the numbers, but the estimate right now is only, I think, about a fifth of the population has been exposed, if that, and we really have no true idea because testing has been so inadequate. But the idea of waves really is it comes from there are, peaks of infection as part of the epidemic curve that is controlled by public health measures that have been put in place. And the risk of a subsequent wave will have to do with whether those control measures are relaxed in a way that exposes more people again and allows the virus to increase its rate of transmission. And because we still have the majority of our population that's naive and susceptible to this virus, and the virus is fairly transmissible, then there's a risk of, here in the United States, a prolonged period of circulation and perhaps an uptick in case numbers or the rate of infection that could be due to the relaxation of control measures. And that's probably going to be very different in different parts of the world, depending on the proportion of the population that's been exposed and potentially has immunity, coupled with the control measures that are in place to limit that. But I think the consensus would be that there's going to be prolonged circulation of this virus. There still isn't any indication that is going to, in the case of a temperate climate like in the United States, that it's going to disappear somehow in the summer and come back, but rather we're probably going to see some sustained transmission at maybe a reduced level with possible spikes. And in the United States context, those spikes might even be asynchronous in different parts of the country, depending on the population density and the control measures in place. And so in Bangladesh, there's going to, it's going to also depend on our understanding of the rate of transmission now and how sustained that is. And then whether the expectation is will be continuous circulation, or if there's some reason to think that circulation and transmission will indeed increase later on. But it's going to have a lot to do with the proportion of the population that gets exposed and whether exposure actually confers immunity and resistance to second infections. But I'll hand off to Steve on this one too, because he probably has good insight into this question. You're on mute, Steve.
Yeah, no, I mean, I agree. I think that we'll know more when we do serological studies, but I would anticipate that we are going to be left with lots of people who are susceptible, and so that this is not going to be, we're not going to be done with this by the end of the year.
Steve, there is one technical question. Under the present situation, what are the challenges that you will be facing with the clinical trials, that you are talking about? And also, can you put some light on HCW contracting infection?
I'm sorry, I didn't catch the second question. Oh, shoot, I'm not hearing. No, you're muted.
HCW, contracting infection in human.
Oh, is it, how are the healthcare workers being?
Yes.
Okay, got it. Okay. So clinical trials are hard. Clinical trials are always hard, but they're particularly hard during a crisis. The way that this is being managed, where I see it being managed particularly well, is both the WHO and the US National Institutes of Health, and they've really learned a lot from the Ebola situation, which is to say that it's really important that we actually do studies so we know. Like a good study evaluating chloroquine that showed that it caused people to die at higher rates than untreated is a really important finding, and you need to have controlled trials to do that. So the way it's being done in the US is to be split across many centers. One of the perverse benefits of there being so many cases is it gives us a lot of statistical power to evaluate a lot of drugs. So we have the power to evaluate differences, and everybody who comes in is then offered, if they meet the entry criteria, they can consent to participate or not. These are also designed as adaptive trials. So now that we have remdesivir being better than placebo, we know everybody gets remdesivir. The trial doesn't stop. We then put another drug in there and see if that works even better. So it's really careful attention to ethics and to consent, being careful about trying to put safe drugs in, and having comparison groups that allow us to be able to stop if there are harmful effects. In terms of healthcare worker transmission, stopping transmission in healthcare centers is really quite difficult, but if there's an intense focus on procedures, how do you put on your masks? How do you take them off? How frequently do you change? Do you change every time you go into the rooms? Are the rooms at negative pressure? So there's an enormous amount of built environment that contributes to reducing risk. There's the use of high quality personal protective equipment. And then the third piece is training and systems in place so that people know what to do and know how to do it. So one of my colleagues, Ashley Stachinsky, is in Bangladesh, and she has been out to some of the hospitals, but we haven't done, and I'm not party to studies in hospitals to know where we think the problems are. But I do think that we do have examples where, with a lot of focus, but also with a lot more resources than is typical in a Bangladesh context, we have been able to reduce risk. And I don't mean to suggest that putting up face shields is going to stop everything. I'm just saying this is another barrier that would be relatively easy for us to put in. And we might think about it in hospitals and in garment factories.
Thank you, Steve. John, there is one important question for you, that you mentioned that you found antibody in community people, those who has regular contact with bat. So do you think that the infection was circulating in communication before the declaration by Chinese government? What do you think?
Well, I think that, and first to be clear, the viruses we had found associated with the communities in Yunnan were related to the original SARS. They were SARS-related coronaviruses, and they were not this virus in particular. So we don't have evidence that this virus was circulating in those communities, and the study was done back in 2015. But I think that the epidemiologic evidence suggests that this virus was circulating in communities at least for a little while before we first became aware of that initial cluster of pneumonia. The other line of evidence that suggests that the virus may recently have been circulating, but not that it's been circulating for more than a month or two prior to our recognition of it, are the analyses done by evolutionary biologists looking at the genome of SARS-CoV-2 and particularly comparing it to its closest known relative, which is a bat coronavirus that we found in Yunnan also, that's 96% similar. And they, SARS-CoV-2 is not derived from that bat virus, but the thought now is that that virus evolved just recently in October or November, a few months before the recognition of that first cluster of cases. So if it was circulating in community, it probably wasn't doing so for, let's say, years, but maybe perhaps for 1 or 2 months before it was recognized. That's at least with the best evidence we have right now. You're on mute, Nitish.
Sorry, yeah. Steve, thank you. John, thank you very much for the response. Steve, there is one question for you. You know, these face shields that you mentioned, is it based on some research, or do you recommend to go for some research before coming to a public announcement that it could be very useful? What is your opinion?
I will share the slides with you, and the slides include a citation for some studies that have been done suggesting that this reduces risk of exposures. These are lab-based studies. I would view these as a low enough risk intervention that it would be worth doing. Fine, it would be fine to do it in a way that you're also observing outcomes. I think that that would be responsible, but I think it has very little downside. And I think that we're in a, so I talked to my group about, we have some research questions around COVID-19, and we have some outbreak responses. And I think this is, I think given the infections that are going on in healthcare workers, given what we hear is going on in the garment factories, I think that we need to do something different than we're doing up to now. And I consider the laboratory data that I cite in the presentation a sufficient justification to do this.
Thank you, Steve. I have another question to both of you. You know, there are quite a good number of questions on this about the diagnosis. You know, at the moment, globally, we are all using the PCR, and PCR, we know the merits and demerits of PCR, and particularly in a very developing country or poor countries, they are not very easy to be used. So what is your suggestion? Because test, test, test. This is a slogan coming from the WHO. How do you really face this challenge? Do you have any alternative comments on this? Over to you.
Well, there are a lot of antigen tests in development. There are a whole lot of them. There are also a lot of serological tests. But serology is not going to help you so much in acute diagnosis. They're really important for the questions that John raised to understand how much of the population is infected, and so how much are still susceptible. So I do think we will have antigen tests, but we just don't have them right now. We know that the PCR works, and we know what a positive tests mean. And one of the problems with having everybody and their cousin develop an antigen test is it's a little harder to sort out what's best. But I will say there are a lot of smart people and a lot of good companies working in this area. So I do suspect that this situation is one that will improve in the coming months.
And just to add to that, testing is a challenge even for developed countries, not just for the developing countries. Clearly, the United States is the poster child for not being able to ramp up testing to an adequate number. And what's particularly challenging about this disease, COVID-19, and particularly in comparison to, say, SARS coronavirus, is the asymptomatic and pre-symptomatic transmission, which means that you can't just rely on identifying symptomatic patients or syndromic surveillance to identify patients and isolate them, that someone could look perfectly healthy and still be spreading this. And that's why the testing becomes so important. And we still don't even understand really to what extent there is asymptomatic transmission. So unfortunately, testing really is crucial to help us understand the epidemiology here.
Thank you. One question to both of you. This establishing separate hospitals for COVID, and that as you see in UK, they have developed a separate hospital, but it remains vacant, and not many cases there. And we are now here in Bangladesh. We are also establishing a separate hospital for COVID. What is your comment on this thing? Professor Mahmoud Rahman has raised this question. Over to you.
Well, it's certainly aligned with WHO recommendations. And the idea is if you can have your COVID patients separate, then you can still have a healthcare system that meets the needs of the other things that people are dying of. The emergency obstetric care, the myocardial infarctions, the acute abdomen. And if you try to have both in one hospital, it can be very difficult to protect the patients coming in for non-COVID reasons. But I think part of this is just raw practicality. So this is what WHO is recommending. But you give the example in China, and I can see what actually, that's what Stanford did initially. They said our Stanford main hospital is only going to be a COVID hospital, and other emergency procedures were sent to other facilities. But now, as they've said, our numbers are coming down, we have it under control, we can change around. But I think, I do think that there are widespread risks of in-hospital transmission. So to the extent that you can prevent that, particularly among those folks who are higher risk, those 60 years old and above.
Any comment from John?
In terms of building facilities, well, the idea of overwhelming healthcare systems was the primary concern in this epidemic. And so I think that being prepared, it's almost better to have hospital beds and not use them than to need them and not have them. So to some extent, the preparation is important. And I think Steve makes a great point about being able to carry out normal functions as well. Because in New York, for example, where we were saturating our hospitals, where there was just no space for other patients, a lot of people were not able to receive emergency health care for things unrelated, and that was a disaster. So that actually increases the mortality rate as well, even indirectly, because people are dying for things that could normally have been addressed in an emergency room.
Yeah, Steve, there is one question. What about the combination of antiviral drugs? The drugs that we are using, and do they really work? I mean, it is a question you could have answered during the drug issue. Can you comment on this?
Yeah, well, the way that the NIH and WHO are doing these trials is to say, what's the drug that we have the most confidence in and that we think looks like the best candidate? So remdesivir was first because animal studies suggested that it was effective against coronaviruses, and we knew that it was safe because of the studies in Ebola. So that was the first one out. Then what they want to do is test it against one after another. And I just don't have on the tip of my tongue their next candidate, but the idea of saying, well, let's take a whole bunch of things and throw it all at once, then somebody might get better, they might get not, they might have a toxic response. I think what instead the plan will be is to try to identify one at a time things that help. And then once we know that there's more than one thing that helps, then they'll try combinations as well. So we're trying to build our knowledge step by step. We can't hear you.
Sorry, yes, sorry. John, please.
Yeah, sorry to interrupt, Nitish. I just wanted to raise, I saw a question flash across the chat room that I thought was particularly interesting in the context of the One Health discussion we're having. So if you don't mind, I wondered if I could address it. And it was a question about what other species are affected by SARS coronavirus 2. And I think it's an important question because, we often talk about the need to integrate livestock and wildlife health into, One Health surveillance and response capacities. And I wanted to just share briefly one of the discussions that's happening in the United States that I think will have relevance to Bangladesh as well. We're in such an unprecedented situation where a bat-borne virus has emerged in the human population, and so many people are going to be infected with this virus that there is legitimately an interesting question about the potential for zoonotic transmission from people into other animals. The idea that other animals may be exposed, and even the possibility that this virus may establish itself in other host species by way of people. And that normally isn't something that you observe very often, but it's something that's interesting here. And so in the United States, the U.S. Fish and Wildlife Service and the National Wildlife Health Center have engaged folks like me and other experts and virologists to ask the question about whether North American bats might be susceptible to infection with COVID-19, with SARS-CoV-2, and in the particular context of bat researchers going out and handling bats, and if they weren't wearing PPE, then the potential to expose bats to this virus. And so I'll just share a little bit about what we know and don't know about other species susceptibility. And there's really two lines of evidence. There's experimental evidence, and there have been some laboratory infections that show, non-human primates, of course, can be infected. Carnivores, much like SARS coronavirus, the original SARS coronavirus, we see that ferrets, felids, cats, whether it's domestic cats or big cats, including tigers, can be infected. Dogs, not so much. And then we're also seeing that there's, aside from experimental infections, looking at the genetics of the virus and the ACE2 receptors. That's the receptor that the virus uses on the cell surfaces, particularly in lung tissue and intestinal tissue. And ACE2 is conserved widely across mammals. A lot of mammals have it, but not all ACE2 receptors are equal. So the virus doesn't have the same level of affinity or ability to use ACE2 in every given species. And so there's been research looking at amino acid sequences and specific amino acids related to the receptor binding domain on SARS-CoV-2 that suggests that cows and other bovids and rodents might also be particularly susceptible to infection. Now, this is theoretical. It's just based on sequence data, and there are limits to that. But I wanted to put this out there because I think it just raises the idea that aside from the human epidemic that is paramount right now, it will be important to conduct surveillance for coronaviruses in wildlife in Bangladesh and livestock to understand whether this virus is co-mingling. For another reason being that coronaviruses in particular have the ability to undergo recombination, that if an individual, animal or person is infected with two strains of coronaviruses that are close enough related, those viruses have the ability to exchange genetic material. And that's a process that forces evolution in coronaviruses. And so understanding how animals might play a role, at least in the evolution of beta coronaviruses in Bangladesh, might provide interesting insights in terms of future risk, in terms of the diversity of coronaviruses circulating. So I just wanted to open that up either as a discussion or as something to think about how this really is a One Health issue ultimately, because this epidemic is going to impact animal health potentially as well.
Yeah, thank you very much. I was about to ask you that question, but you have picked up and it was... Thank you very much. That's a very good explanation. And in relation to that, there are quite a good number of questions I think you have covered. But there is one question there. Is there any possibility of gifting or shifting of the current SARS coronavirus type 2, which may make the life more complicated?
Well, like John says, I mean, these viruses are known to well, I mean, they can not only recombine, but they also mutate. These are viruses that mutate. These are an RNA virus. They're not rock steady. I would say that this strain has adapted to humans and seems to be doing quite fit in that way. Will we get a vaccine that works against one strain and then get antigenic shift? I think it's possible, but because the receptor binding domain is so crucial for this virus, I'm assuming that vaccine is going to target that area, and it'll just be a matter of about how robust it is. One of the things that makes influenza so difficult is because the neuraminidase and the hemagglutinin change all the time and change a little bit, and their whole uptake is different. So yes, I think this virus will continue to change. I think one of the things it teaches us is if it's not this coronavirus, it's another coronavirus we need to worry about. We need to better understand spillover risks. We need to eliminate illegal animal trade and live markets. And we need to have a more robust vaccine and pharmaceutical response to this class of pathogens.
John?
Yeah, well, I also see the question about whether there's a risk of spillover in Bangladesh, and we've studied coronavirus diversity in Bangladesh through the PREDICT project and other activities, and we know that bats, including Pteropus, carry diverse coronaviruses that are probably have co-evolved with those species, and we don't yet know whether those have the ability to infect people, whether they're zoonotic, but it's something that needs further exploration and something that should be done, because we know that there's contact between people and bats in Bangladesh in various ways. And with Nipa virus being an example where we focus on a particular pathogen and a route of spillover, we have to remember that if there's a way for one virus to get out of an animal and people, that's probably a way that other viruses can do that as well. And so we really do need to understand mechanisms of spillover and think about different groups of viruses and the potential for them to jump as well. And that's something that requires more study.
Yeah, John, could you follow up on that a little bit? So for a long time, it seemed like people were saying that the coronaviruses were in horseshoe bats, but PREDICT and Simon Anthony's article suggests that coronaviruses are in fact found across many families of bats, including Pteropus bats.
That's right. So to put a finer point on it, the SARS-related coronaviruses, the group of beta coronaviruses that are most genetically like the original SARS coronavirus, tend to be found in horseshoe bats. But bats are an enormous group of mammals, right? More than 1,400 species. And not only bats, but in fact, all mammals have their associated coronaviruses. That is a huge family of viruses. But evolutionarily, mammalian coronaviruses appear to have originated in bats. Most of the evidence suggests that originally these viruses came from bats, including the human coronaviruses. And so different bats carry different coronaviruses. And across that family tree, we're just starting to fill that in. So the viruses we find in Pteropus that are coronaviruses aren't closely related to the SARS-like coronaviruses in horseshoe bats, but we found coronaviruses in African fruit bats that are MERS-like, that are related to Middle East respiratory syndrome. So we have to continue to characterize those viruses and start to assess whether there's the potential for them to infect other species as well.
And the co-infection, can it make it different, because what is your point? I mean, what do you think about the co-infection of different coronavirus in the same host?
Coronavirus co-infection is possible, and I'm not sure that it's been described yet, but there are human coronaviruses circulating now seasonally in the United States, and it's very possible that people may be infected with both one of the 4 human coronaviruses at the same time as SARS-CoV-2, and I haven't seen that reported. Steve, maybe you have, but we just don't know the answer about co-infection other than it's possible, and that's certainly how viruses may recombine. But again, the coronaviruses have to be closely related genetically to make them most likely to recombine. It's not that any two coronaviruses do that. And so it really depends. Another question I think about is with MERS, in areas where MERS is enzootic in dromedary camels, in the Middle East and Northern Africa, is there a potential for SARS-CoV-2 to co-infect camels and have some kind of recombination event? And that's just something that needs exploration as well.
Thank you very much. I am coming to one question, it is a combination of different questions. The model that, Steve, you have presented on the demographic structure, can you not really develop a sort of global strategy based on this, demographic distribution? I mean, currently, we are focusing all in the same strategy. Can it be a separate strategy globally and locally and nationally? What do you think?
Yeah, I think we need to have different strategies. If you think about how many people in Bangladesh and how many people in even countries that are more poor, like in sub-Saharan Africa, whose family depends, they live in the informal economy, and they every day need to earn their money with pulling a rickshaw or whatever labor they can do so that they can buy their rice and maybe a little bit of dal. And that's how they get along. A lockdown directly undermines their ability to live. So we all on this connection live in relative affluence, but you also live in a country where there's a lot of poverty. And so I think that a lockdown has an enormous societal price. I see this in the state of California among people who live paycheck to paycheck. And I think this is very true in our low income, particularly the urban slum communities, because those folks tend to be working in the informal sector. They're living in very crowded conditions. And so I think this is going to present differently. In some sense, I think it will run through those communities quickly when it does. I think it will exact a high mortality. But because there's so much crowding, nearly everybody will be infected, and then it'll be done. And I think it may be quite different from those of us who successfully physically distant, socially distance, and so we don't get infected, but we remain at risk. And so then that creates a difficult balance as well. In the US, different states are doing different things. I think many countries initially said, oh, they want to do what Europe did, they want to do what the US did. But I think these countries are increasingly questioning, like you have seen in Pakistan, or like you see the decision by the government in Bangladesh to open the garment factories. I think countries are going to be experiencing with trying to get economies going so poor people can afford to live. And I think people will die. People are going to die from this terrible pandemic. And I think countries are going to have to make decisions about how much you can protect by stopping everything and how you have to balance that against people being able to earn a living.
Thank you. I think we have to go for the last question. This is last question that we always ask. What is the future of One Health? Is it going to be like what we have been practicing, or it is going to be different, or One Health approach will die off? What is your comment from both of you?
Well, I'll start and then hand over to Steve for the last word. My opinion, One Health is more necessary than ever. How many examples of global pandemics is it going to take for us to understand the connection, not only between human and animal health, but the really important fact that human activity is the single biggest driver of epidemics, that the ways that we are changing the environment around us that influences the way that we contact wildlife and the way our domestic animals contact wildlife is influencing opportunity for spillover and emergence of zoonotic diseases. And it's only going to be through a One Health approach that we can examine not only the nature of those interactions, how wildlife and livestock are coming into contact, how often pathogens are making the jump from wildlife into livestock or into people, but also it's going to take a concerted effort to figure out how to make those activities safer, because we're not going to stop them from happening. As human populations grow, it's inevitable that we're going to continue to pressure and put pressure on natural systems, but we have to, in a practical, in a feasible, in a locally relevant way, try to make those activities safer. And that's going to take the complete picture, perspectives from the animal health world, human health world, from social scientists, and most importantly, from local scientists, folks who understand the cultural context around which you have to make decisions to modify behavior. And so I think that is the single biggest argument for a One Health approach in being able to stop epidemics from happening. I'll end there.
Yeah, I really agree with John's sentiments. I think that this that the COVID-19 outbreak illustrates that we can't just address these things with the medical model. We need to understand, we need to be preventing, and prevention really rests in understanding how we're impacting the environment so that these spillovers are occurring. And I just keep coming back to the illegal animal trade and live markets, which we have been saying have been a problem for a long time, and certainly since the SARS outbreak. So I do think that One Health becomes even more important as more and more folks begin to make this connection, that I think we as a community also need to push for better policies so that there is not so much damage done to the natural environment, so that we protect natural ecologies, and so that we do not set up these live markets with wild animals particularly that set us up for yet another pandemic.
Thank you, Steve. Thank you so much, John. It is so exciting and all very enlightening. There are so many questions in front of me, and I will certainly forward some of the very pertinent questions that I have not been able to raise here. There are very good questions like herd immunity and the shedding of the viruses and all others. Many questions are there. I will be forwarding to all of you kindly to respond to them. But it is almost more than an hour. I have to stop here. And Steve and John, you are so kind, in this late night in your part of the world. You are so kind, and I know you both like Bangladesh, and I hope you will continue to do that. We are passing through a real difficult time, and I believe that we will be able to win this situation, And today it was so insightful. What that we are doing now goes along with the discussion that you have already made. We learn a lot, and I will be following. Before I conclude, I just want to make a housekeeping announcement that we will have another webinar in next Thursday, and we'll circulate it today or tomorrow. And thank you so much for attending. And it looks so many enthusiastic people attended, and still they are coming up with questions. But I will send all those questions to you. As always, Steve and John, it was so nice to see you with us. It looks like that we are physically even in Bangladesh. Thank you very much. And stay well. All my friends, those who have attended, thank you so much for making it a success. Thank you. Here is the end of our today's webinar. Thank you very much.
Thank you, Nitish. Have a good day.
Thank you.
Stay safe.
We will send the answer of the questions via your email.
Okay.
Thank you.